Hey, Dr. Coyce, emergency physician here. We're going to go back and talk about part 3 of the STEMI case that I had. Go back and look at the timeline. You can see part 1 where we talked about the actual cardiac catheterization, and then part 2 where we talked about what the ECG looked like. So this was a 63-year-old female who came in with chest pain. Now, something happened that was a little bit curious, that doesn't always happen, but it demonstrated how the teamwork within healthcare really operates. The ED tech gave me the ECG, and the ECG's label showed a different patient who came in with a skin complaint. So I'm looking at this ECG that looks terrible. And at the same time, there's a woman who is in another room right adjacent from where I'm sitting that looks like she's having a heart attack. And I'm thinking, does this ECG match the actual patient that it says it does? So anyway, we took the ECG in to see the patient, and the tech was there as well. And we were able to confirm that the ECG was labeled incorrectly, and we corrected that. So we already identified that the patient had a STEMI, and we were working on giving her all the medicines and transferring her out of our hospital so she could get an emergency cardiac catheterization. So we had to go on to the history. Now, the patient came in, she did have high blood pressure in the department, but she's going through this massive event with her body and she's in a ton of pain. So she's got a big sympathomimetic drive, plus part of her heart isn't getting blood. So the body is actually trying to boost the amount of epinephrine that she has in her body in order to supply blood to her vital organs. The history from the patient is that she only has hypothyroidism, so takes levothyroxine to supplement her thyroid hormone. When I go back to the computer, I have a look through her history, and I see with the last couple of office visits, her blood pressure has been somewhere between 130 and 140 systolic, so maybe a little bit of mild hypertension, and really not a whole lot else. But here's the kicker. From 3 months earlier, the patient had a lipid profile, and the LDL cholesterol was 191. The non-HDL was about 186, something like that. Not treated with any sort of lipid-lowering therapy, and the non-HDL was elevated as well, which means the ApoB, even though it wasn't measured, was likely still very high. This was the only lipid test that I could see in the chart, but I suspect that the patient's lipids have been elevated for a very long time, thus building her risk for cardiovascular disease and the eventual MI that she had. Now, because the patient was out of our emergency department with about 45 minutes, which is the gold standard, we need to get door to balloon times less than 90 minutes, we didn't really get into the nitty-gritty about what the patient's lifestyle looked like. So I didn't really understand what sort of exercise she was doing, what her real dietary components were. She wasn't a smoker. She said she drank alcohol, but not that regularly. So while some of these may have led to increased risk, certainly the elevated cholesterol was a massive red flag as a cause of her MI.